All right. Well, thank you very much again for asking me to come to this podium. It's truly an honor. These kinds of lectures are a little bit more didactic, so we've tried our best to include maybe a little question and answer session here, but a whole hour of question and answers afterwards to be able to jump off of some of the things that I'm going to talk about today. The good thing about Parkinson's disease is that it's impossible to give an update in the research and new developments in Parkinson's disease in an hour. That's actually a really good thing, right? Because there are many disorders in neurology where we say, well, the update is, well, there isn't one. Whereas in Parkinson's disease, thankfully, that is not the case, which is a very positive thing, and there's lots of research going on in many fields, and obviously we can't cover all of this. So as any, hopefully, good speaker, I'm going to try and concentrate on 2 or 3 important things that I think are valuable. First part of it is research done, that some of it which we've done in collaboration with other people, and the latter half of the talk is based on research that we do in our lab, and specifically concentrating on therapy and new aspects of treatment for Parkinson's disease. So let's start with diagnosis. The diagnosis of Parkinson's disease still remains in the hands of the expert doctor. What this means is that it's always good to have access to a specialist that knows about the disease, and the intricacies of the disease are many. In fact, I routinely have fellows and students that come from geriatrics or internal medicine, and I tell them that coming for 2 days to a movement disorder clinic is completely insufficient in being able to manage a disease such as Parkinson's. Just for example, we're going to talk about levodopa. Levodopa is a drug that's been around a long time, but it is one of the most complicated pharmacological drugs to use. And if you have not had experience in using that product extensively, you don't know the nuances of how to manage a patient with Parkinson's disease. So when we first started this program 20 years ago, Dr. Andrew Parent, who's the chief of neurosurgery, and I decided that even though he's an excellent Parkinson DBS surgeon, he would not be able to manage the disease, which meant that after the technical part of the DBS was done, I would have to take over the management again. Why? Because unlike, for example, essential tremor, where after you do DBS for essential tremor, people that have benign essential tremor, he can do the programming of the pacemaker. And in fact, my patients with essential tremor are transferred to the surgeon for management of the DBS device. Not so in Parkinson's disease. So this disease requires somebody that is really a movement disorder specialist, if not at least a general neurologist. I truly feel that outside of those 2 people that are potentially even above the movement disorder neurologist, management of Parkinson's disease in other people's hands is really dependent on their the extent of their experience. And that's something that you be careful with, because most people have a busy practice doing other things, and hence the diagnostic dilemma or difficulty can occur in these non-specialized centers, right? So even in our hands, the diagnostic accuracy of Parkinson's disease in the first year is about 92 to 93%. So we still miss about 8% in our hands, having seen 10,000 PD patients. In the community, it's about 50%. So the error is very high in misdiagnosis of Parkinson's disease. So that's something so it remains really a clinical diagnosis. In fact, to some extent, as a movement disorder neurologist, I went into the field for that aspect of movement disorders being a really clinical specialty. And that's not the case with many other aspects of neurology. You wouldn't diagnose somebody with a stroke without doing an MRI. Parkinson's, there's no such thing, which means that there are no tests to diagnose Parkinson's disease. I'm the gold standard, supposedly, right? And people like me who actually have I suppose, the experience and the vision and the ability to put together a very complex group of symptoms and come up with a formulation, which is what we call a diagnosis. There's no MRI, no CT scans, no such imaging techniques. No matter what we say in terms of research, there really isn't anything diagnostic. So there's an imaging technique called TRODAT, which is available in the US and it's available in other parts of the world. But the ability to predict Parkinson's disease or diagnose Parkinson's disease early in the course of the illness is not good with these techniques. Of course, 5 years later, once the person clearly has Parkinson's disease, the imaging is positive, well, but then I can tell that they've got Parkinson's disease, no reason to image, right? So this is where the difficulty lies in terms of all of those techniques, so we don't rely on them. Lots of stuff in the literature, media, sweat testing, bowel biopsies, et cetera, to diagnose Parkinson's disease have come about from this complexity of the fact that Parkinson's disease is not simply a disease of the dopamine neuron, but it actually affects many, many other parts of the body. And why not, right? All cells in the body have the same chromosomes, exactly the same. Some become brain cells, some become prostate cells. But the chromosomes are exactly the same. So it is possible that if you have abnormality in processing of proteins or whatever it is inside a cell, you'd be able to see that in other body parts as well. So in fact, that's where the last 10 years or attempts have been to look at whether sleep predicts Parkinson's disease better or constipation predicts Parkinson's disease better have come about. Unfortunately, none of them have really panned out to be specific enough for a particular disorder like Parkinson's disease. Hence, we don't do bowel biopsies, we don't do sweat gland biopsies, etc. And it's been there in the literature of people that, I think there was an article in the UK that a woman could smell her her spouse's sweat and say that he had Parkinson's, something like this. Yeah, well, I mean, I don't go about smelling patients. It's a sort of a problem. If I start doing that, then that's a, yeah. Anyway, so I have to stop practice. Same thing applies with genetic testing, right? So genetics has become, there are 23,000 genes in our body. And what we realized is that what we thought was a very linear genetics, one chromosome has one gene that's transferred over to the next, et cetera. That doesn't work in most disorders. Even conditions like Huntington's, where the genetics was supposedly very clear, has become very blurred now because people are finding that the patient has a gene for Huntington's disease but doesn't have any symptoms late into disease. That's something we didn't expect. So the genetics of Parkinson's disease is also very complicated. Hence, from a diagnostic perspective, it's still a clinical diagnosis. In our big meetings, we had MDS meeting in June in Vancouver. Again, it remains in the hands of the clinician so far. Practice of medicine is such that when that translates into an accurate diagnostic test, you might call it biomarker or whatever, then we do relinquish command to those tests. That's why the example of stroke. You wouldn't diagnose somebody with a pneumonia without doing a chest x-ray anymore. In the old days when I trained, you would actually put a stethoscope and listen to somebody's chest and then diagnose pneumonia better. Or that way. Even though we had chest x-rays available there. Now, there really is no reason to even do that because the diagnostic accuracy of that test is far better than ours. The judgment is still clinical as to how sick the patient is. So we don't use any diagnostic tests in patients with Parkinson's disease. Hence, if you're somebody new with new onset of symptoms and you go to a competent movement disorder neurologist, you probably won't get any tests done, right? And you might walk out of there saying, gee, they didn't do any testing, at least hemoglobin. But no, there really is no diagnostic certainty from any of these tests. So diagnosis remains clinical. So the diagnosis or the diagnostic basis is the clinical presentation. And here's the problem. Parkinson's disease is not a homogeneous disease. There are as many variants of the phenotype, how you look, as many variants of the phenotype of Parkinson's disease as there are patients with Parkinson's disease. Some have more tremor, some have more gait, some have more speech, others don't. So in fact, this variation creates the diagnostic uncertainty in those people that have not seen many. That's the reason why you want to go to somebody that has seen 10,000. We see between 60 to 100 patients a week. So by the time I've done this now 25 years, literally you can do the arithmetic of tens of thousands of cases that we've evaluated. So the variety and pattern that is in my head is so large that I can actually say, yeah, that still looks like that looks like it, that looks like it, etc. And that's very true for any subspecialty, and that's why you go to somebody that has a lot of experience. So these variations, however, also have implications in terms of what patients feel their disease is like as compared to somebody else. Well, I look like this, how come he's like that? And now somebody's like this. He's treating them with that, and they're treating them with... This kind of variation is very common in management of Parkinson's disease because the phenotype, or what a person looks like, determines how we manage them, right? So I might titrate somebody's levodopa to a particular level, but not in somebody else. I might add something, suggest surgery in somebody, not in the others. So this management plan is very different than managing, say, hypertension, where if you have high blood pressure, we put you on ramipril, and everybody gets ramipril or perindopril or something like this, beta blockers, very straightforward management, right? It's more like insulin, where your sugar, but even there, the tailoring of insulin is far simpler than tailoring the management of Parkinson's disease medications, right? So a unique form, for example, just as an example, has been termed benign tremulous Parkinsonism. Now, these are patients who have the typical Parkinsonian tremor, but it's in the upper and lower body, trunk is shaking, have it for a long time. And normally, we used to teach that somebody that has long-standing just tremor probably has benign tremor, but that's not the case. In these patients, they respond to levodopa. So they actually have a Parkinson's disease-like state, except that they have really only tremor and remains tremor. This is different than tremor-dominant Parkinson's disease, where you have all the other symptoms, happens to be that tremor is more than the others. So these variations have become, even today, after Parkinson, this is the 200th year of description of Parkinson by James Parkinson. It was described thousands of years before, but yet we're finding new phenotypes, new looks of the same disease that we've known for so long, right? And this is a discovery literally in the last, not discovery, but a recognition of the type in the last 10 years, right? So this is something that I've been doing this for 25 years, as I said. I didn't know about it, and we probably saw lots of people who didn't recognize it, right? So the course of that condition being benign, what it's telling you, though, that we don't really know what Parkinson's disease actually is, or we know that Parkinson's disease has many, many faces, right? So your individual Parkinson's disease is different than other people's, and hence you need that expertise of that person that has that exposure to as many phenotypes as possible. Right? So what causes PD is, again, these are one or two slides on each of these before we get into what I really want to talk about today. And the answer largely is still completely unknown as to what it is that causes Parkinson's. The cop-out answer is that, well, it's in your genes and something happens to you afterwards. And that basically is true for every possible disease on the planet. So it doesn't really tell you something about Parkinson's disease. However, it is true that there are certain predispositions, certain genetic factors that people are looking at, including us here. And one of my collaborators, Dr. Steve Pasternak, has is looking at a therapy for a particular type of enzymatic deficiency that we see in a disease called Gaucher's disease, and looking at the treatment in that disease to try and map it onto treating Parkinson's disease. So there is some significant interest in the population for this being a predisposing genetics as compared to a causative genetics. You know what I mean? So it's something that predisposes you for getting a disease if something else happens. What that something else is unknown to us at the moment. Obviously, most of us most of the people that have Parkinson's disease don't take drugs IV, so it's not related to MPTP, which is a toxin. It's not related to the environment. We're not really sure exactly what it is in the environment that might be doing it, because Parkinson's is present everywhere. I spent the last week doing clinics all over the north and middle part of India, 5 days, 5 cities, teaching and doing clinics. Parkinson's disease is there as well, right? So it's not something that is present only in one particular population north of the equator, et cetera. So we really don't have such specific indicators that we screen for. So neither do we have diagnostic tests, nor do we screen for genetics, nor do we have a specific list of things that we ask patients specifically in terms of exposure. This is important because patients do come to our clinic often and say, well, you know, I was working in this environment, or I was a farmer. What about these kinds of toxins that I might have been exposed to? Yes, it's possible, but we really don't have a handle on why it is that so many people were exposed to it, but you got it, and why it is that many people got it but were not exposed to the toxin. So both those large error boundaries have made it difficult for us to have one particular thing that we screen for. I will say, though, that manganese and welding has been looked at as one potential risk factor. And if you're a manganese miner, or if you've been exposed to heavy-duty fumes of manganese from welding, there is an accepted potential causative link. And in fact, you can get a disability in the US and even in Canada if that has been something you've been exposed to. That's the only link that we've really looked at. Now, infectious disease, on the other hand, can cause Parkinsonism. And in fact, the movie Awakenings that all of you, I'm sure, have seen is linked to post-encephalitic Parkinsonism. And that's still endemic in the world, right? We don't see it in North America as much because influenza has not been rampant in the last little while. But Japanese bee encephalitis, for example, has been around for many, many years. In China and Asia, Japanese bee is endemic. So if you have somebody with acute onset Parkinsonism, chances are it's infectious Japanese bee encephalitis. Right? But that's not Parkinson's disease again. This is another variant or face of presentation of Parkinsonism, which is not the same as Parkinson's disease that we see in the population. So such variations make it very difficult for us to screen for something specific. But that's where the state of the art of causation of Parkinson's disease at the moment is. Risk factors such as sleep, et cetera, have been linked to degenerative disease. So if you sleep very badly for many years, chances are you're going to have a neurodegenerative disease. Not particularly surprising, because what we feel about sleep is that it's a way of systems to heal. So if you don't allow a system to heal properly, chances are the system is going to degenerate, right? So if you never stop your car running, then chances are it's going to run out sooner. So this is the idea behind those kinds of premotor symptoms that, such as REM behavior disorder. Okay. So treatment, and this is where I'm going to concentrate now from now on in terms of what it is that is new, because we could talk about each of those topics for a whole hour each, and we'll all fall asleep, which is not a good thing. So in terms of treatment, because people finally do want to know what we're doing in terms of making quality of life better, right? And so the four big categories, dopamine replacement, enzyme inhibitors, anticholinergics are the three treatments that remain as our mainstay, right? So levodopa and the dopamine agonists, which we're not going to talk about each of these, is old news. Enzyme inhibitors, what are they? They are those drugs that slow the breakdown of the levodopa that you're taking, right? So if you take levodopa, like any product, your orange juice and coffee, it's broken down by the liver, muscle, etc., and degraded and thrown out of the body. Well, we want to slow that down so that levodopa is available for longer in your brain. Well, those are the enzyme inhibitors, the two. I won't go into what they are, but entacapone is a COMT inhibitor, rosagiline is a MAO inhibitor. These will slow down how quickly the drug is broken down, so it kind of effectively lasts longer. So keep heating your coffee in again and again, so you can drink the coffee hot over the next little while, otherwise it gets cold. Same idea here. Anticholinergics are another group, a completely different group of medications that we use. Very rarely do we use them in typical Parkinson's disease patients because the side effects are quite few, many. And younger Parkinson patients that have really a lot of tremor, we do use anticholinergics. We're not going to talk about that. And then there are lots of treatments available for non-motor symptoms. And I've, at this podium and many talks like this that I've given to the group here, I've given talks on constipation management, sleep management, drooling, etc., which, again, talk in itself, which we won't be able to do. Then there's surgical treatment. We've talked about deep brain stimulation intracerebrally into the brain. Many people, maybe some of you have even had it. We do a lot here. We've been doing this now 20 years. We've done over 250 some odd DBS cases. The new Duopod pump, which is a therapy I'll talk about briefly, is also available now in the last year and a half or two in London, and it's available in Hamilton as well, and a couple of the other and several centers in Canada. It's been in Europe for many years. And then something unique that we've developed, which I will talk about, a spinal cord stimulation for gait freezing, and we're the only center in the world that's doing that, so amongst other things. So I'll talk a little bit about that. So we're going to concentrate on levodopa. Why? Well, it is still the flagship drug for us. It's the 50th anniversary of the use of levodopa in the Americas, and not 50th anniversary of the use of levodopa in the world. It was used 10 years before. And prior to the initiation of levodopa, anticholinergics that we talked about briefly, physical therapy, and then thalamic surgery, which is surgery into an area of brain called the thalamus. That's all that we could offer. We, in the sense, I wasn't doing medicine at that point in time when levodopa was used. I was 2, so I wouldn't be prescribing anything. I was being prescribed 2, however. But so at the same time as levodopa was introduced, it actually eliminated all those other treatments. What does that mean? That means the discovery of levodopa and usage of levodopa was a home run. It worked so well that everything else paled in comparison. And hence, levodopa has continued to be the dominant gold standard. And in treatment of Parkinson's disease, that's an important point, because for many years, in the last 30 years, there have been attempts to come up with new molecules that are better than levodopa, and everybody has failed, right? There's been nothing else that has been manufactured that is better than levodopa. Hence, in the last 5 years, as you'll see in the next few slides, there's been a lot of interest in how do we make levodopa better. Makes sense, right? I mean, if your car is really running well, but only one little problem here or 2 other problems there, you try to fix your car, you don't get a new one. Levodopa is like this. It's already a really good drug. So instead of coming up with another molecule that is better than something that already works so well, why not concentrate on things such as delivery, such as packaging, etc. So I'll show you what is new in the literature now and what's coming to market in terms of packaging, delivering an already efficacious product. And that pharma industry has learned that it's better, not only in terms of making our patients better, but also potentially for making profit by making something better that's already working. So the chances of failing are much lower, right? And so that's what I'm going to talk about. But before that, I just want to really, again, highlight, in such an old drug, but it's still misused all the time. It's the way in which levodopa is given by physicians, how it's prescribed, is still very poor. Levodopa is 2 drugs in combination. There's 2 drugs, carbidopa, that helps make sure that levodopa reaches the brain. What does that mean? That, remember I told you that levodopa is broken down? Well, those 2 enzyme inhibitors that I talked about are two that are important, but the most important one is one that metabolizes levodopa to dopamine. It's called AADC. That enzyme takes levodopa, which has some molecules on it, cuts it off, and makes it into the active dopamine. Levodopa is not a short form for dopamine. It's dopa is short form for another protein called dihydroxyphenylalanine, which is actually a protein, right? And so this enzyme has to be blocked. Otherwise, what ends up happening is that in your body, before it gets to the brain, levodopa is made into dopamine. Why is that a problem? It's a problem because dopamine doesn't cross the blood-brain barrier and has to be given as levodopa. It has to be given as a precursor. It has to enter the brain and then convert it to dopamine. If the conversion happens before, nothing's going to get into the brain. And even with all of the enzyme inhibition, only about 10% gets into the brain. So if you take 100 milligrams of levodopa, only 10 is getting into the brain, right, at the best of times. So it's really important that you use the drugs properly. Those two drugs are different in all of their pharmacology. So the person that's prescribing needs to know this. And I find this all the time. Just yesterday, we had a senior medical resident in our clinic, no idea about the pharmacology of levodopa, yet potentially in a year this person can be prescribing. And that's not the individual's fault. It's simply that we don't teach it properly. It's important because then a patient is given this medication incorrectly. They're told that it doesn't work, or they think that it doesn't work. And that's bad because this is the best drug we got, right? And so you're already eliminating something that's our flagship home run drug by not giving it properly, right? And even today, this is happening all the time, right? So take it on an empty stomach as much as possible, maybe with just a small amount of food because it does cause a bit of nausea, and no proteins for 1 hour. I know this is all old hat for people that are using this all the time, but I still see patients all the time taking it with a glass of milk. Not a good idea, right? Doesn't work, right? You got to take it on an empty stomach or some crackers, a glass of apple juice or something like this. 1 hour before, doesn't mean you don't need any proteins. You eat it, but 1 hour later, right? So this is just very simplistic. I always try to hammer this point, right? Most of us dose every 4 hours, but some may need 5 and more, et cetera, right? So because of the fact that you often need more as the disease progresses is the concept of now the new things, duodopa. Duodopa is a proprietary gel. And even when I was a fellow 25 years ago in the previous century, we actually were using some formulation of what was called liquid levodopa. Why were we using liquid levodopa? Well, some people really had such brittle on-off times, which means that the drug worked but didn't work so quickly that we couldn't dose people every 4 hours. It was too long. Yet at the same time, taking pills every hour, every 45 minutes was too much because they were getting a full pill, or half a pill was not easy to break. So to avoid or to deal with that problem, we would crush the tablets. We'd get the patient to take 1,000 milligrams, crush it, put in a liter of water, put some vitamin C in it to stabilize it, shake it every time, and take a teaspoonful. That allowed us to give 25 milligrams every 55 minutes, that kind of a thing. But it was a real pain because obviously you had to carry this bottle. It had to be a dark bottle because the levodopa settled down. Yes, most patients with Parkinson's have tremors, so they don't have any problem shaking the bottle. Sorry. But at the same time, pouring it into a cup was very difficult, right? So, yeah. I've done this 30 years, so I guess I can joke about it. But at the same time, it is an important thing, though, because when you're talking about giving therapy to a patient, you're going to be very cognizant of their ability and disability, right? So, and this was a big problem because now the caregiver had to do this all the time. So long story short, in the last 10 years or so, the company AbbVie, or before that, another company that was doing this, has come up with a proprietary gel pack. And the gel pack I'll show you in a second. And that gel pack is on a cassette. And it's kind of like my pager. It's a bit bigger than that. And if I can get it out, maybe I can't get it out. Okay, like this. Right? It's much bigger than that, but it's a cassette. That cassette is put in, and we train the individual or the caregiver to start the pump, and then it's a 16, 18-hour pump that goes all night, or all day, sorry. And you don't have to do anything. You start the pump in the morning, and you got your levodopa all day. This duodopa pump for both motor and non-motor symptoms are helped by this, and it's a 24-hour, actually it's 16 hours, but sometimes we do use it for 24 hours, single cassette, and the 24-hour preliminary observations show that it works for that time as well. Not only actually does it show symptom improvement, but also shows that the brain changes as you are exposed to longer-term levodopa, which we are not going to get into, but it may actually stabilize how the brain is responding to the medication, as compared to pulsatile, where you take pill and then 4 hours later another pill, so you got this up and down. I'll show you some other new inventions that are trying to smooth that out. Well, duodopa's attempt is to do that, right? And here's that pump. you can see that on the, I don't have any way to point to anything at the moment, but you can see that on the left-hand side, that the stomach and the jejunum, there's a tube that's floated down in there, and that pump is attached to that tube. This one? So what do I point to? Oh, this screen? Oh, this screen, I'm going to fall off this one. Okay, all right. So, okay, thank you. So as you can see, that's the pump, and I'm going to have to shout now. So, and that's actually the device, and so it sits on a strap, or you can strap it around your abdomen, and patients carry it. It is actually somewhat heavy, so if you're frail, then it is something that we have to worry about. But the way it is set is that we bring the person into hospital, not inpatient, but for 3, 4, 5 days. We do a lot of other interesting tests that we're not going to talk about today. And then we program the device to be able to give you a morning shot, and it gives you a boost in the morning, and then gives you a regular pop, 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 pop every minute. So you don't have to worry about food or anything like this. It's continuous all the way till you go to bed. And as I said, if you have enough left in the package, it has 2,000 milligrams of levodopa in it. We can even use it overnight. One of the practical reasons to not use it overnight is that if you're mobile during the night, then you might actually pull on the tube, et cetera. So it's better to not do it at night. So that's the Duodopa pump, right? One of the problems that we realized, however, with the Duodopa pump is a problem that has been known for a long time, and that's of peripheral neuropathy. What is that? Well, peripheral neuropathy, I've got data on there just because I have to appear scientific, but you don't have to worry about reading the numbers there, but to show that it's validated by real data, not just made up by my opinion. So peripheral neuropathy is injury to the peripheral nerves. Diabetics get peripheral neuropathy, right? Lots of vitamin deficiency syndromes cause peripheral neuropathy. When we were using levodopa in smaller quantities, oral levodopa, there was always an indication that patients with Parkinson's disease got this peripheral neuropathy. But with duodopa pump therapy, it has become obvious that this is something we have to watch out for. And that's related to consumption of vitamins B6 and B12. So if you are indeed getting duodopa pump therapy, or even having tingling, numbness, etc. with Parkinson's disease, it may be related to consumption of those vitamins. So it's a good idea to be able to test for those things if you have experienced those symptoms. And the reason to bring it out is because in this duodopa therapy, the incidence was quite high, and something we have to watch out for. Why is this important? Well, it's our peripheral nerves that tell us our joints' position sense, our vibration sense as to where we are in space. So diabetics are at a big fall risk because of the peripheral neuropathy, because they don't feel where their legs are. Right? So here's a patient with Parkinson's disease who already has gait and balance and postural difficulty, and now potentially develops peripheral neuropathy. So it's something we have to watch out for and screen and treat. Right? It's a bit of a problem because vitamin B6 is both a friend and a foe. What does that mean? That means vitamin B6 is used in the metabolism of levodopa, and hence B6 can be consumed. It gets used up. So if I'm making 50 cups of coffee, I'm not only going to run out of coffee, I'm going to potentially run out of milk. Right? So I got to keep track of that, right? So there's no point just saying, okay, well, 50 cups of coffee, I got to buy more coffee. Well, no, the next 50 cups, there ain't no milk. And it happens in my lab all the time, right? So I've got a coffee, but no milk. And so this is something that you have to worry about in terms of B6 and levodopa. Levodopa consumption and conversion uses up B6. At the same time, B6 also impedes the conversion of levodopa. So it has both friend and foe action. If too much B6 will cause reduction in the benefit of levodopa. Too little B6 causes peripheral neuropathy, gets used up. So you got to be careful as to how you manage. Again, remember, expertise. So people that are not aware of this are not going to be looking for this in your patients. So be careful if you're having somebody's managing you and not testing this in you if you have those symptoms. So B6, B12 regularly need to be done. There's some other complex issues in terms of metabolism of levodopa. For example, there's a lot of interest over many years of using levodopa and increasing another metabolite called homocysteine. And this has a slight increase in risk factor for stroke. So how often are we going to worry about it? Well, not in those patients that are getting routine levodopa therapy by mouth. But if you start converting people to these pump therapies, then you have to be careful that you're not putting people at risk for those other things. So again, this has to be managed. On the pump therapy, B6, B12, homocysteine levels, etc., have to be measured. right, properly. So as new therapies come out, more complications are being revealed to us. Right, so we talked about it a little bit, and the advantage of this, of course, is that it works really well. It smooths the day out for people. And you can imagine somebody's taking every hour and a half oral medication. They've tried other things and are on 1,500 milligrams of levodopa. You put a pump in and they're free. Right? So they're able to start in the morning at 6 and then go till midnight without having any oral medication of levodopa required. No protein interactions, nothing. Right? So that's why the therapy is actually very good. I'm not going to talk about DBS surgery because it's been talked about before, but this is a new thing in the last couple of years in Canada. It has had a lot of experience in Europe. It's been around for 10 years, so it's not new therapy from that perspective. Okay, the next interesting thing is this thing called the Accordion Pill. How do you get a lot of levodopa into somebody, a lot of levodopa, over a period of time? Well, you can't give them a tablet that's this big because I don't know if you can swallow it, right? And so besides the fact that it'll choke you, you're not actually going to be able to deliver the tablet in the slow release way that you want. So this is an interesting formulation that has been tested, which is, you can see on the right-hand side, it's a capsule. So it's a capsule, but it's got folded into it this accordion. It's actually like an accordion, the back part of the accordion that I don't play the thing, but it's whatever that, what is that called? The pressy thing, the bellows. Yes, all right, yeah, the bellows. So the bellows is what this technology is. It's got layers of levodopa, and then it's made into this bellows, folded and put into a capsule. You swallow it, the capsule dissolves, and the bellows expand, and you don't hear any sound. But it's simply just. You want to hear an accordion from your abdomen is not necessarily pleasant all the time. And then the levodopa is released slowly over time, right? So slowly over time. So, and in fact, it has been tested, and here's the data there, and it's kind of backward presented in this paper. So the blue is bad because it's high, and the red is good. So what you're seeing there is that, on the left-hand side graphs, is that the off time and the amount of time with dyskinesia in the two graphs, the two on the right here, significantly better with this device, similar to what we've seen before with Cinemat CR. And also this graph, which shows that, remember I told you that pulse up and down, kind of my mouth? Well, this accordion pill seems to smooth that out a little bit better. Again, the idea is same levodopa, how do we package it together? With the Duodopa pump, we package it as a gel, which is stuck into your jejunum. With the accordion pill, it's folded into this thing, put into a capsule, so it releases slowly over time, and you've got layers after layers of release, so it's there for a long period of time. Right? So the idea is reduce how many times you have to take the drug. Right? So this is another way of delivering the same efficacious medication that we know so far. Right? Then subcutaneous pump, and this has been tested. In fact, we were supposed to do the trial here, but it was quite onerous, and I didn't feel that we had the staff to do this. But this is a pump therapy that's been designed in Israel, and the idea behind this is, unlike the jejunal pump, where you've got to put the catheter into the stomach and actually have a surgical procedure, this is subcutaneous. So the patient or the caregiver is supposed to do this, right? So you stick needles in there and you clip it on, again, like that, like it shows over there in the picture. And there's a levodopa delivery system in that little pouch, and you press it on and it delivers it subcutaneously. For many years, levodopa has been tried intravenously and subcutaneously, but it causes a lot of irritation and sclerosis of the blood vessels. This new formulation doesn't do that. So that's been tested. Phase 2 studies have been completed, and in fact, it shows the same thing. It works. Well, why not? It's levodopa. But the thing is, the efficacy of delivery is easier. Again, you don't have to have a surgical procedure now. You can have this done on a daily basis. The caregiver just basically inserts 2 little needles subcutaneously in one body part and straps it on and starts it, and you're done for the day. Right? So that's the idea. Best drug out there to relieve the symptoms all day without having to take pills all the time, not forgetting them, etc. So again, this subcutaneous pump therapy is going to come to the market. It's in phase 3 studies as we speak now. Right? And so the next thing is another interesting, and again, as I said, there's a lot of data there, but it's important to have the data. People can read it. It's not difficult to read. These are now studies that we've done here in London as one of the multiple centers. What is CVT-301? Well, I talked about the fact that levodopa is a combination of 2 products. It's absorbed in the intestine. It's actually absorbed in a small part of the small bowel called the jejunum. And in fact, that's where we float that catheter, and that's where the accordion pill will be absorbed. The problem is there's competition with protein in the absorption across the bowel, right? And this is important because if you have all of these regulations that you have to follow, it may very well be that dose 1 works, but dose 2 doesn't work, dose 3 doesn't work, and dose 4 works. This erratic delivery system makes fluctuations occur in patients with Parkinson's disease as one of the reasons why. Well, this particular CVT-201 product is an inhaled product, right? So it's a puffer, like an asthma puffer. Right? Works really well. We just finished the phase 3 studies. It's been published now, and it is useful. The lung does not have any protein absorption because we don't eat in our lungs most of the time. So because of that, there's no interaction across the alveoli, right? So if you take a puff of levodopa, it goes instantaneously by diffusion into the bloodstream. So the time of onset is faster. Right? Very quick. So you could be off, for example, you go to the mall and you feel that you're off, you can shake this thing like asthma puffer and take it, breathe a couple of times, and within minutes, supposedly, but it takes about 10, 15 minutes for this to get into the bloodstream, as compared to taking oral tablet of levodopa, which takes 45 minutes, right? And it works really well. We've had quite a few patients that have done very well on this puffer technology. What it doesn't have in it is carbidopa, the other drug that I was talking about that helps levodopa get into the brain. So it's only useful for those people that are on levodopa, carbidopa by mouth. And in adjunct to that, as you need, you take an extra puffer. But it's good to have, right? I mean, you could take your tablet at 7 in the morning, and you know that it works about 9:30, and that means regularly you can't go out because you're going to go off, and then you have to have your tablet with you, a bottle of water to swallow it. It takes 45 minutes. The advantage of this is that you carry your puffer with you. And in case you go off and you're at Walmart, you puff. And that's the reason why they've developed this. Again, it's levodopa, right? Another way of delivering the same efficacious product. Pump, subcutaneous pump, accordion pill, puffer, right? So that's actually where the pharma industry is heading, as I've said, to be able to use the best friend that we've got, just make them better, right? Or delivery better, et cetera. So that's CVT-301. The next product, which has already been tested, it's on the market now for several years, is this drug called Rightterry, which I think many of you might have heard of. It's not available in Canada yet. But again, it is another longer way of delivering the same product, levodopa, right? And these are just studies that I've named their apex. We participated in this study as well, quite a few patients in this study. And at a dose that is there, that I've talked about, it was efficacious, right? It was very useful. It did have a longer duration of action. Cinnamon CR, some of you that are probably on it, is a similar attempt, but it doesn't work very well. Rightterry worked better than what our experience with Cinnamon CR. Still doesn't mean it's once a day, but it is something that's also potentially coming to Canada, I hope, in the next little while. It has been available in the US. So this is now a particulate extended release. We talked about the accordion. This is another way of packaging levodopa as particles, right? And then another product from them, which we won't need to talk about here, I just talked about, is bead technology. So they've taken levodopa and made it into small little beads that dissolve slower. Okay? So hopefully I'm giving you the ideas as to how a lot of these pharma companies have changed their focus from coming with brand new compounds which fail and don't work better than levodopa, but to actually take the product that works so well, as I say, home run, and package it better through the lung, through the intestine, as a bead, as a particle, as an accordion pill, so that patients can take advantage of the best drug that we've got. Right? Otherwise, we only have one way of delivering it, which is the yellow pill, and that's it, finished. That's what we've had all these years, right? And instead of that, these new technologies and delivery systems are going to help us a great deal to be able to provide more tailored therapy. Those that need the pump get the pump. Those that need the accordion pill, these are how we deliver. Somebody, let's say, that has been a chronic smoker, maybe puffer is not going to work for them because they've got a poor lung capacity, et cetera. So, so far we've had no such separate delivery systems, but the technology has moved there in the last 10 years, actually, literally in the last 5-7 years. Okay? I'm going to show you something really cute. Let's watch this commercial.
Is developing Orafuse, the first device to continuously deliver drugs into the mouth at a controlled rate. Many vital drugs are short-lived and are rapidly broken down in the body, sometimes in just minutes. Intermittent dosing of these drugs causes wide swings in their concentrations in the body. A high concentration increases dangerous side effects, while a low concentration is often ineffective. For example, people with advanced Parkinson's disease experience many hours per day of impaired movement because their levodopa concentrations are too low or too high. Dosing of such drugs, even 6 or 8 times per day, does not provide adequate relief to many patients. Patients need a better way to deliver these short-lived drugs. Orifuse is the first device to continuously deliver drugs into the mouth at a controlled rate, achieving stable drug levels in the body throughout the day. Orifuse consists of a custom-fit reusable orthodontic retainer and a miniature disposable propellant-driven drug pump. To use Orifuse, the patient inserts a fresh drug pump into the retainer, removes the cap to start the flow of the drug, and then places the retainer onto the teeth. The drug is continuously delivered to the back of the mouth, where it is swallowed with the saliva and absorbed through the gastrointestinal route. At preset intervals of up to 1 week, the depleted drug pump is replaced. Orifuse does not interfere with speech, swallowing, drinking, or sleep. The drug is delivered so slowly that patients do not notice the delivery and do not perceive any taste. It is discreet and not visible to others. Orifuse is easily removed for meals and for toothbrushing. Orifuse will be the first non-invasive system for continuous delivery.
Not bad, no? It's an interesting idea. So I talked to the people that manufactured this at a meeting a few months ago, and indeed, it's a clip-on that you put on, and it's another new patented way of delivering with the propellant levodopa in your mouth. It tastes really bad normally, but this doesn't taste bad apparently. I didn't try it, but it doesn't taste very bad. So what they did in this study, I've just highlighted the day 2, 3, and 4. Patients were brought into clinic, and day 2 they were given their regular medicine. Day 3 they were given the suspension of levodopa, and day 4 efficacy study, etc. And it worked. I mean, it's levodopa again, but the convenience factor is there, right? So you're delivering a new way, or you've produced a new way of delivering levodopa in patients that otherwise would have had to take this by mouth. You can imagine somebody having swallowing difficulty having to take levodopa, right? So this is something that you could easily consider as a clip-on when it comes to market, and I'm sure it will as the technology advances further in the next few years, right? So, and that was the trial design, right? And this is just the data that shows the same thing that I showed before, that in those patients that had the up and down like this, it is smoother, and in fact, the dispensation caused a reduction in what you saw over there in terms of at 1 hour, in terms of the off time that you would see, whereas oral medication was not as good. And the serum concentrations gradually increased over time as expected. But it's still levodopa, which is great, right? Then there's one last levodopa compound which we'll talk about, which is the deuterated levodopa. So here, instead of hydrogen, deuterium is substituted into the levodopa. This is artificially made levodopa with deuterium, and this can potentially increase the half-life, right? And resulting in much more. So here's now levodopa, whose half-life is only 90 minutes. If you deuterate the hydrogen, so this is a benzene. I'm not going to go to the lesson in organic chemistry, but it's a benzene ring. It's a benzene ring levodopa. Levodopa with 2 hydroxyl groups and a chain that looks like this. So what they've done here is they've replaced the hydrogens with deuterium, right? And the idea behind it is that it slows down how quickly that levodopa is metabolized from instead of 90 minutes to 4 hours, right? Which is a substantial increase, right? It's 4 times longer. And in this case, then, if you've given somebody, so this is now a very innovative way of producing CR, controlled release. Why is this important? Well, it's crucial, right? Because levodopa is only absorbed in a small part of the intestine called the jejunum. So no matter how much we make the formulation slow release, once it gets past that region of the small bowel, there's nowhere for it to be absorbed. It doesn't get absorbed in the other part of the small bowel or the large bowel or your rectum. It doesn't get absorbed. So you may have a pill that's sitting there for days as you're constipated, but it doesn't get anywhere. Right? You're not absorbing it, right? So you need the pill to get in quickly, but then the drug not break down as fast, you see? So that's the thing. Otherwise, it won't be absorbed. So this is still absorbed in the same part, this SD1077, still absorbed in the jejunum, but once it's absorbed, it lasts a lot longer, right? So its shelf life in the body, instead of being 90 minutes, is much longer. So this is another formulation which enables frequent dosing, so less frequent dosing, reduction in dosing, and again, another way of changing the compound that works really well, okay? Now, there was another slide in between which I must have forgotten. So let me just go back a little bit. So that's, okay, right. So that's all about levodopa. and how other people, including some of us that have participated in trials, have managed to take that compound to the next level. Now we're going to go into the realm of what we've done here for two specific symptoms. The two specific symptoms that we've concentrated on for today's talk are gait freezing and tremor. Both those symptoms do not have any treatment, even with all these wonderful, nifty formulations of levodopa, because the treatment of gait freezing is zero, and DBS doesn't work either. And the treatment of tremor, which is persistent, which does not respond to oral medications, also zero. These two are big unmet problems amongst many in Parkinson's disease treatment. So we, in our lab, as a couple of projects, have concentrated on this, and this has worked extremely well. I want to show you that data. Okay? So we took 5, we've got many more now, and we actually are enrolling now. So for those people that have very significant, what we call on-freezing, make sure your doctors can talk to us about this, because we're enrolling patients, and we're the only center in the world doing this. So this paper is coming out next week in our flagship journal, Movement Disorders, about these first 5 patients that we've done with spinal cord stimulation. This is a technique, which is an outpatient technique, where we put a device over the mid-thoracic spinal cord, right about here, right? And program that, just like the DBS device, except that this is in the on the spinal cord, not in the spinal cord. So it takes about an hour to do the procedure, and you go home. Unlike DBS, where you have to stay in hospital and we have to program, there's nothing the side effects are minimal. So we took 5 patients, 71 years of age, who had very severe history of falls and severe freezing. One of the members was actually wheelchair bound, right? And this is the spinal cord stimulator there. You see, that's where we place it, right? And that's the device, the spinal cord stimulator device. So the device is there. Those are the electrodes that go on the spinal cord, and this is the pacemaker, very similar to the DBS device that some of you might have seen, and maybe have heard me speak about it or others speak about it, right? And so there's a huge therapeutic need. As I said, gait dysfunction, there's no treatment, zero, right? So there has been a little bit of data, only 28 cases reported in the world so far, and almost all of those cases had pain, because it's approved for pain treatment. So in fact, it was realized in a group of Parkinson patients that had significant back pain that put in the spinal cord stimulator and their gait improved. But the problem there was we were not really sure whether it was because of the pain improvement or gait improvement, right? So instead of that, what we decided to do was we were going to explore this in patients who didn't have pain, who had significant freezing of gait, who were stuck, couldn't walk, even to the point of being wheelchair bound, as I said, right? And that's what we did. So here's one of the aspects of our lab. So this is an individual that has significant amount of freezing. As you can see down below, those are his footfalls, right? Those are his footfalls, and so you can imagine he's walking like this continuously with Olivia standing there. And this is a xenoprokinetic walkway which records that, right? And so very significant gait difficulty, disability, right? So we measured a whole bunch of things. We're not going to talk about their step length and width and velocity and variability and stance time and symmetry and whatnot. All of these are important variables of gait that you're measuring, right? And so we did all of that. And that was our demographics, as I said already, about 71 years of age, 15 years of disease. We did the ambulatory walking, et cetera, and we put that there. Oh, repeated. Oh, sorry, the pictures are repeated. And then we tested a whole bunch of settings, including what's called pulse width and frequency of stimulation, how much we're delivering in terms of current, right? And we tried to see what was the best setting in combination of all of those things for each participant, right? Acutely, at 1 month, 4 months, and 6 months post-surgery. So here we go. This is participant number 1. I don't think I need to explain to you that the middle graph shows improvement. Right? So that's the first graph, shows what the gait looked like. And the second graph below, after we programmed it to that 400 microsecond, 60 hertz setting. It wasn't as good if you had the 200 microsecond, 60 hertz. Can you imagine if you go from that first to walking like this? I mean, that's free walking, right? The second patient that was wheelchair bound was able to get out of the wheelchair and walk, right? So is that good? Not good. So we've done 10 people now, and here's at 6 months post-op, right? So just on medication, this is just on medication. This is post-stimulation. So free walking. Those are the gait, the gait cycles that you can see. By the time he walked from one end to the other on the first trial, he's already walked 6 times back and forth on the mat in the other 2. Right? So, yeah. And this is participant number 2. This is a gentleman that was wheelchair bound, and that was what he was on the top graph. I mean, again, self-explanatory graph. This is him trying to walk on medication, right? And this is him tested with yes, and this is off, worst setting. Right? So there's a clear difference in terms of gait. And this has persisted now at a year. We had 1 year follow-up with these people now. And so it's lasted a year long. And this is at 6 months, 6 months post-op, it's the same thing. I mean, if you you'll see that, wait, it's not playing. Do you have to click it? Anyway, it doesn't matter. It's the same thing. Doesn't matter. We're probably running out of time. What we showed there was that if you look at the balance scale confidence, right? These people were not confident before they were walking. And by the time this study at 24 weeks, very much increased in their confidence. Their Parkinson's rating scale also improved by that time, right? So these are people that are at severe ends of their spectrum of their gait. These are 15 years into disease, 70 years old, had disease for 15 years, and not able to walk. So this is going to revolutionize how we treat gait in terms of Parkinson's disease. We just got a big grant to put in 15 more in patients with Parkinson's disease who have severe on-gait freezing, and we've just started recruitment. We got our first patient the other day. Okay. The next and last little topic I want to present is tremor. Again, something that we've developed in our lab, which has now become worldwide, where people are now recruiting patients for our studies for this from across the US and Canada to start with. And tremor, and this is an individual that has very significant tremor with Parkinson's disease. And I presume the second video is playing, or can you play that? The second video on the right? Yeah, that one, yeah. That's it, yeah, on the right. Yeah, click that one. Oh, it is playing. Oh, okay. Yes. Sorry, I always get this right. Yeah, it is playing. You can see that the reason that it looks so good is because there's no tremor. Yeah. Sorry. That was a joke. So that I do every time. So, oh, yeah, well, the video must be frozen because where's the tremor? But it isn't. And in fact, that's what we see. And now we've done 100 patients worth of injections, several years, multiple papers published on this. It works remarkably well. About 80% success rate we have in terms of treatment of essential tremor and Parkinsonian tremor with botulinum toxin, right? So what we do is this. We've actually designed a system, we won't go through that, so we won't talk about that. We've designed a system using wireless sensors. Those are wired sensors, but now it's completely wireless, where we put on sensors on the person's arm, we get them to do a bunch of things, rest, posture, etc., and we record the tremor. We've written all the algorithms in the software to extract the features of the tremor, and then our software predicts, because I trained it, predicts how much to inject in which muscles, and then we inject that. That's what we do. Right? Problem right now is that all the grants that we have for enrollment of new patients are over, so there's no enrollment going on. But for those people that actually can afford to get the botulinum toxin and pay for it, we can do that for them at the moment. In a few years, hopefully, it'll be available for everybody on the market. And these are the sensors that we use, goniometers, et cetera, and the wrist, elbow, and shoulder. And then that the system provides us with a little graph. Down on the right-hand side, I show you that graph as to how much flexion extension, how much rotation, how much elbow, how much shoulder. It gives us all of that breakdown. It also then teaches me, because I trained it, how to inject, not how to inject, but which muscles are involved in that motion. Then I inject those muscles. And it even gives me the dose. So, it does that, and it reduces it dramatically. I'm going to quickly show you a couple of graphs, which all you got to do is look at the stars on the downtrend. That's tremor improving, right? And not only is it improving in Parkinson's disease, we also, this is an essential tremor, and we've got now 4 years worth of data, and it's persistent, continuous improvement, right? And so everything improves. So action tremor improves, rest tremor improves, improvement in handwriting, pouring, activities, daily living, quality of life, and this is Parkinson's disease, and this is essential tremor. It improves dramatically. So this is now, hopefully in the next 3-4 years, going to become a standard of practice. This is essential tremor. Parkinson's disease is the same, right? And here's the mild weakness that you get from botulinum toxin injection. Right? And so I want to stop there. The first part of it was related to other people's work and how we helped in participating in other people's work. The last two are based on the work that we've done in our lab as to bring new therapies to unmet needs in treatment of Parkinson's disease. And of course, I want to thank all the people that are in my lab. These are not all of them, but many of them that do the work for me, and so that I can stand up here and talk. Thank you very much.